Hi everyone, today we're going to be talking about the pancreas. We're going to cover the anatomy, some normal variations, a little bit of physiology, and then in another lecture I'm going to cover the pathology of the pancreas. So the pancreas is going to lie anterior to the first and second lumbar bodies of the spine. It's located in the epigastrium and in the left hypochondrium. If you'll recall, the epigastrium sits sort of under that xiphoid process. Left hypochondrium sits behind the left side of the ribs, okay? It's also going to be behind the lesser omental sac. Your major posterior landmarks are going to be the aorta and the IVC. If you'll recall from your sonographic images, they sit towards the bottom of your screen below the pancreas. We're actually talking behind the pancreas there. And then it's going to extend in a horizontal oblique lie from the second portion of the duodenum or the C-loop of the duodenum to the splenic hilum. So the head is going to be medial and the tail is going to be lateral. It also sits, the tail sits slightly higher than the head. It's an oblique lie. Variations can include transverse, meaning it doesn't have that oblique tail a little bit higher than the head, horseshoe, sigmoid, L-shaped, and inverted V. Most of the pancreas is going to lie in the retroperitoneal cavity, except for a little bit of the head, which is intraperitoneal. It's surrounded by the peritoneum. It's going to occupy that anterior pararenal space, so the space surrounding the kidney, and it's going to lie, as we said, obliquely between that C-loop and the splenic hilum. The tail is going to point to the hilum of the spleen. Behind the pancreas, you're going to get connective vertebral tissues, the portosplenic confluence. Remember, we see this on sonograph also. It sits towards the bottom of the screen. Behind the pancreas, you've got the splenic vein running into the superior mesenteric vein. They combine and form that portal vein that then runs superior towards the liver. You're going to have those superior mesenteric vessels, the vein and the artery. Then posterior to that, the aorta and the IVC sitting on the left and right sides of the spine, respectively, and the lower border of the diaphragm. Your stomach, the duodenum, and the transverse colon are going to form the superior and the lateral borders of the pancreas, and they're also going to run anterior. The stomach and the transverse colon are going to run anterior to the pancreas. So the pancreas is divided into 4 areas. They're going to be the head, the neck, the body, and the tail. Now the head is the most inferior portion of the gland. It's anterior to the IVC, right lateral to the portosplenic confluence. It's going to be inferior to the main portal vein and the caudate lobe of the liver, and it's going to be medial to the duodenum. The uncinate process is part of the head. Sometimes you're going to hear it sort of defined as its own little piece, but it's actually the tip of the head, and it lies anterior to the IVC, posterior to the superior mesenteric vein. It's going to wrap around that superior mesenteric vein, okay? The neck lies between the pancreatic body and the head. It's directly anterior to the portosplenic confluence. It's going to be right in front of it. The body's the largest section. It's going to be anterior to the aorta and the celiac trunk. It's inferior to the splenic artery. The splenic artery, remember, is one of those branches off of the celiac trunk that we talked about last week. The celiac trunk has 3 main branches: the splenic artery, the common hepatic artery, and the left gastric artery. The tail is the most difficult part to image, and it's going to be anterior to the left kidney. It's going to be posterior to the transverse colon, which is why it's hard to see because the gas from the bowel gets in the way, and also posterior to that left colic flexure, left lateral of the aorta, and medial to the splenic hilum. It's anterior to the splenic vein. That's why that portosplenic confluence, that splenic vein looks like it's running behind the pancreas on your screen sonographically. Okay, I'm just going to hang out quietly here for a moment and give you an opportunity to see if you can label all of the structures around the pancreas and the parts of the pancreas. You can pause the video if you need more time. Okay, let's see how you did. Got my little laser pointer. We're just going to run through these real quick. So here's our pancreas right here in the center, right? We got the head, the neck, the body, and the tail. And notice this little tip that runs behind that superior mesenteric vein. That is that uncinate process. Okay. Stomach is going to be in front of it. We've cut it away so you can see the pancreas. Liver, anterior and superior. This is the C loop of the duodenum here. It's that head of the pancreas nestles in that C loop, and the tail of the pancreas points to the spleen. Now, you weren't asked to label these vessels up here, but remember that's that celiac trunk. You've got the splenic artery running along to the spleen. On the other side, you got the common hepatic artery. It splits into the gastroduodenal artery and the proper hepatic artery, which runs up into the liver. Not seen on this picture is the left gastric artery. Okay, so keep moving along. We got right kidney lateral to the C loop of the duodenum and inferior and posterior to the liver. Down here, we have that right colic flexure, also known as the hepatic flexure of the large intestine. Cut away, because it runs in front of the pancreas, is the transverse colon over to that left colic flexure, also known as the splenic flexure of the large intestine. Posterior to that and inferior to the spleen, down here in the back, that's that left kidney. You can see it just peeking out here. And then down here we've got some vessels, right? We got the aorta, the IVC. This here is the superior mesenteric vein. And this one here is the superior mesenteric artery. So we have some ducts that run inside the pancreas. The main duct, the primary one, is called the duct of Wirsung, or the main pancreatic duct. It's going to extend the entire length of the gland, and it receives tributaries from the lobules at right angles, and it enters the medial second part of the duodenum along with the common bile duct at the ampulla of Vater. Okay, it's guarded by the sphincter of Oddi. So the common bile duct runs superior to inferior, goes through the head of the pancreas to join with that duct of Wirsung, and then it enters the duodenum through the ampulla of Vater. The duct of Santorini is a secondary duct. It's going to drain the upper anterior portion of the head of the pancreas, and it's going to hook up with the duct of Wirsung in the majority of cases. There are a few anatomic variations that we'll touch on, but that's the general gist, is it's going to meet with that main pancreatic duct. So let's talk about what it should look like sonographically. You should be able to see the head, the neck, the body, and the tail. The head, the size is going to be less than 3 centimeters. The neck should be less than 2.5 centimeters. The body less than 2.5 centimeters, and then the tail less than 2 centimeters. The echogenicity, you think it should be slightly brighter, slightly hyperechoic to the liver. It's going to be isoechoic, possibly hypo, possibly hyperechoic to the spleen. That's going to depend on the fatty tissue involved. It should be homogeneous, right? We want it to have a nice, smooth texture. And the surface should also be smooth. It may be slightly lobular. Let's see if I can outline that for you. And we're going to show kind of where all of these things are, right? So here is the left lobe of the liver. Right behind that, we got the pancreas. This dark spot here is that portosplenic confluence. We can see a little bit of the splenic vein running right there. Okay, we got aorta right here, IVC over here, horseshoe shape with the shadow behind it, that's the spine. Okay, and then we got right here this little dot right behind the laser. I'm going to move the laser so you can see it. That right there, that's the common bile duct. Now the pancreas is this, I'm going to trace it for you. It's all of this. Notice that the border of that pancreas is very smooth. It's not fuzzy. We can see the borders of the pancreas quite well. Okay, if we go down to the bottom picture, we got left lobe of the liver here. We got pancreas here. Behind that, we got splenic vein running into that portosplenic confluence. This little dot right here, again, right behind my laser pointer, I'm going to move it in just a moment. It's surrounded by a hyperechoic ring. That's the superior mesenteric artery, which is the second anterior branch off the aorta. Immediately behind the superior mesenteric artery, we see the left renal vein sneaking in between it and the aorta and dumping into the IVC over here. Immediately behind that left renal vein is the aorta, and immediately behind the aorta, we can see that hyperechoic horseshoe shape with the shadow that is the spine. All right, I'm going to pick up the speed a little bit because we're already at 12 minutes and I'm determined to try and finish this in under 20. I was hoping for under 15. So here we go. Main vascular supply are going to be the splenic and the pancreaticoduodenal arteries. Okay, so splenic artery is going to run all the way along that superior part of this pancreas, and it's going to have a number of branches coming off of it that are going to feed the pancreas. The pancreaticoduodenal artery supplies the head of the pancreas and part of the duodenum, and it's going to be found at that C loop, okay, where the C loop of the duodenum is. Now the splenic artery itself has 4 smaller arteries: the suprapancreatic, the pancreatic, the prepancreatic, and the prehilar. And those are going to supply the body and the tail of the pancreas. If you recall, the pancreaticoduodenal artery and the splenic artery are the main supplies. That's going to be the most important part. If you could name the other 4, that's great, but it's not absolutely necessary. And then venous drainage is through tributaries of the splenic vein and the superior mesenteric vein, which makes total sense, right? Because they are in proximity to the pancreas. So of course the pancreas is going to drain into those things that are right next to them. Okay, landmarks, things that you can use to find the pancreas. All right, the celiac axis and its branches are going to be your main vascular landmarks. That splenic artery coming off the celiac trunk, you're going to know that the pancreas is immediately inferior to that. The common hepatic artery, the gastroduodenal artery. Gastroduodenal artery is going to be a little hypoechoic dot or anechoic dot close to the head of the pancreas. You're going to see the superior mesenteric artery, the portal vein and tributaries. Those are going to be major landmarks, right? If we look for that portal splenic confluence and that splenic vein running into it, we know the pancreas is going to be immediately anterior to that. And then you're going to want to find that common bile duct too. You can use the common bile duct to follow it to the head of the pancreas, or you can use the pancreas to find the common bile duct. That covers the main points of the anatomy. I want to quickly go over some congenital anomalies. You can have agenesis. This is agenesis of the body and the tail, in which case you're going to have hypertrophy of the pancreatic head, right? It has to be bigger because we don't have a body or a tail. We can have pancreas divisum. This is a rare condition, and it's caused by the lack of fusion of the dorsal and ventral pancreatic buds. So instead of coming together, you get a divided pancreas. The main thing you're going to see with this is the duct of Santorini and the duct of Wirsung are not going to come together. This duct of Santorini is going to exit and drain out of the pancreas separate from the duct of Wirsung. Ectopic pancreatic tissue. Anytime you see the word ectopic, you should think outside of its normal location. If we have an ectopic pregnancy, it's outside of the uterus. If we have ectopic pancreatic tissue, it's going to be somewhere else in the GI tract, and it can be in a number of different places. Generally, it's going to be small, and the bad thing about it is it's going to be subject to acute pancreatitis or tumor, so it's going to raise your risk for pancreatic cancer. And then annular pancreas is very rare, and it's a condition where the head of the pancreas is going to surround the second part of the duodenum and sort of squeeze it off. And we see it more common in males than in females. And one of the common problems with it, of course, is it leads to digestive issues because it's cutting off the, squeezing off and narrowing, stricturing off that duodenum. Okay, so here's a sonographic picture that divides them. Let's talk quickly about the anatomy and then we'll look at that ultrasound. So our standard pancreatic duct, right, that we got the duct of Wirsung. Let's put that highlighter on. There we go, duct of Wirsung, right? You got the duct of Santorini, and the two of them come together and they dump into the duodenum. On divisum, what you get is the duct of Wirsung running in on its own, and the Santorini, the duct of Santorini, also running in on its own, instead of the two of them running together. Okay, now what that's going to look like most of the time, you're not going to see this on ultrasound. It's very hard to determine it sonographically, but sometimes if we've got some other things going on, we can see it. Now, what we've got here is everything with a P is pancreas, okay? You've got pancreas here. We're not going to worry too much about all the other stuff going on, but I want you to be able to make out this pancreas, okay? Right in the center of the pancreas, we've got a pseudocyst. We've got splenic vein here, superior mesenteric artery here, IVC here. But you can see that there are two sections to that pancreas, and they're divided by this cystic structure, okay? So that's pancreatic divisum. We're going to move on to annular pancreas. Annular pancreas, remember we said it wraps around the duodenum. So typically, here's our stomach, right? Pylorus, duodenum here. There's that C-loop, okay? This is the first part of the duodenum, and then this is the second part of the duodenum here. Now, normally, your pancreas sits, remember, nestled in right here. But you can see what happened here. It's like it got that duodenum in its fist, and the head of the pancreas is running around that duodenum. So what you're going to see on ultrasound is here's our pancreas. I'm going to outline it for you again. Okay, we lose it a little over here, comes back here. This is all pancreas. Okay, everything I just did. Notice that the head of the pancreas is hypertrophied. Okay, now this thing that's pointing here to the circular is duodenum. I'm going to trace that for you too. So duodenum is here. Let's actually just do it with a pen. Okay, let's see here. There we go. Pick a color, and I'm just going to circle that for you. All of this is duodenum right in here. And you can see it's squeezed down. You can see a little bit of fluid in the duodenum. Okay, and that's happening because that pancreas is wrapping around it. That's annular pancreas. Okay, quickly, we're going to run through the physiology. The pancreas has two functions. It has an exocrine function and an endocrine function. It's one of the few organs in our body that does more than one thing. So the exocrine function is the digestive part of the physiology of the pancreas. It's going to produce the pancreatic juice in the acini cells, and it's going to deliver that to the duodenum along with the bile. This is essential for normal intestinal digestion and absorption of food. The pancreatic juice is basic. It's an alkaline, not an acid. So it's actually much more caustic than our stomach acid. Now, the endocrine function is the hormonal part of the gland, and it's going to control the secretion of glucagons and insulin into the blood. So this is what helps us to maintain our blood sugar. If we have failure to furnish enough insulin, we're going to see diabetes mellitus. And you want to know which cells do which, okay? So remember, those acini cells are the exocrine function, the digestive part, make the pancreatic juice. The islets of Langerhans are the endocrine function, and they're going to help with insulin and glucagons. A little more on those acini cells. They're going to produce up to 2 liters of pancreatic juice per day. Inside that pancreatic juice, we're going to see lipase, amylase, trypsin, chymotrypsinogen, carboxypeptidase, and nucleases. And what all of those things are going to do is help to digest fats, carbohydrates, proteins, and nucleic acids. Again, heavily alkaline. It has a high concentration of sodium bicarbonate in it, and its job is to sort of neutralize the gastric acid from the stomach when it hits the duodenum. Okay, so that's the acini cells and the exocrine function. The endocrine function, remember I said, was the insulin part, or the part that helps to control blood sugar. And these are located in the islets of the Langerhans. Harlan Ellison wrote a great little short science fiction story called Adrift in the Isles of the Langerhans. So that's why I always remember this. Specialized cells are in there. They're called the alpha, beta, and delta cells. The beta cells are the ones that produce insulin. They're going to be the most common cell in the islet. Okay, the alpha cells, they produce the glucagon, and then the delta cells are the smallest part of the endocrine tissue, and they produce somatostatin. All of those are going to be released into the bloodstream, which is the other way you can keep things separated. The endocrine function goes into the bloodstream. The exocrine function goes into the digestive system. Next up and last, we want to talk about those laboratory tests that are common to the pancreas. These are things that they're going to test anytime somebody comes in with epigastric pain or concern for acute pancreatitis. The first one is amylase. Remember we said that was a digestive enzyme for carbohydrates. And if we have pancreatitis, right, we're going to see an increase in serum amylase, okay? Then with the urine amylase, right, the urine amylase, that's also going to go up in the cases of acute pancreatitis. And also with things like mumps, ischemic bowel is another one. Anything like that. Pelvic inflammatory disease in women will increase that as well, crazily enough. Okay, and then lipase. Lipase again is going to go up. It's going to increase in the presence of acute pancreatitis. Okay, and glucose. Glucose is one that they're going to test for when they're concerned about the insulin production, the endocrine function. So glucose is going to be related to blood sugar levels, okay? That's everything, the high points of the anatomy and the physiology, those sonographic landmarks, and the anatomic variations. I'm going to do a second presentation on common pathologies.